final session of this year's AY PG orientation. এই সেশনটা হচ্ছে OSCE। তো OSCE-তে Dr. Sumanto Datta will show you the questions. There will be 10 questions and you have got sheets for this. তোমরা সবাই A4 sheet পেয়েছো। Write your answers in the A4 sheets and keep the sheets with you. Later on, in the second phase, we will show you the answers. You will tally the answers with the answers you have written and find out what went wrong, what was the mistake, or if it is correct, then it's okay.
Good afternoon, everybody. At the fag end of the academic feast of 2-day long program arranged by AOIWB, we are now at OSCE station. We have our faculties, Dr. Soumitra Kumar, Associate Professor, and Dr. Tithi Debnath, Assistant Professor to PKG Medical College with me, and I am Dr. Sumanto Kumar Datta. At the outset, I shall show you the roadmap of this session. It will be a 1.5 hour dedicated session comprising of mock test and answers discussion session. First 40 minutes will be for the mock test, 10 stations each including 4 minutes time, 40 minutes there. In between 10 seconds will be provided for resting your brain in between 2 stations, and after completion of the mock test, which will be written in your answer scripts, the pages supplied there, we the faculties will discuss, will rerun the program again with the same questionnaire and the answers also. You will check with your answer script, and if any doubt or any clarification is needed from the faculties, will be provided at that time. And at the end of the session, at first the mock test, then the answer session. If you have any specific doubt, you will ask the faculties. This is the roadmap of today's OSCE. Now the instruction to the students: 10 stations, 10 questions, 10 marks each, will comprise of 4 choices. 4 minutes allotted for each station, and that will be a phase out manner. It will start at 4 minutes time, and at 00 it will disappear from the screen of its own. So you have to answer by 4 minutes. So altogether 100 marks will be there. Have your seat. Now the session will start. You get prepared for the mock test. Here is the first station. It will phase out after 4 minutes. Discussion session, you will check of your own the mistakes you have done, if any. We as the faculty expect mistake free answers, but if by any chance, if any mistake is there, you will rectify of your own. Nobody will criticize yourself, the questionnaire, the mistakes you made, you put your marks there and assess yourself. So may I request Dr. Tithi to discuss on this, the history. Here is the answer key. Dr. Tithi, please.
First of all, how was the overall OSCE experience?
What is your experience, madam is asking?
Is it easy, moderate, tough, very tough?
How will you score the faculties regarding your experience? It was moderate, not tough, not easy even. Okay, moderate is safe side.
Okay.
You discuss now.
So, the
You
previous
check
slide.
your answers. You go there.
What is the most probable diagnosis from the history given above? So, I guess most of our, you write it correctly. It's Meniere's disease. And why it is Meniere's? Can anyone tell what is the Baroness criteria for Meniere's disease? Just, there are 4 criteria.
Patient will give a history of dizziness, tinnitus, ear fullness.
Yes, good. But the Barani Society actually created a criteria to diagnose Meniere's disease. They told that if you diagnose any vertigo as Meniere's, then there should be 4 criteria. One is greater than 2 spontaneous episodes of vertigo lasting more than 20 minutes to 12 hours. It's very much important. It's lasting longer. Okay. Then the second point is audiometrically proven low to mid frequency hearing loss, sensorineural hearing loss, low to mid frequency. Okay. Then the third one is, you told it, fluctuating hearing loss. And the fourth one is no other better alternative diagnosis is made. Okay. Then the next question. What is the phenomenon that the lady experienced in the DJ party last night? So it is again common, that is Tullio's phenomenon. So what other condition do you find Tullio's phenomenon other than Meniere's? Good, very good. And congenital syphilis, good. And another common one, perilymphatic fistula. Yes, okay. And in the late phase of Meniere's disease, there is another phenomenon happening. This is Tullio's, and that is Tumarkin's otolithic crisis. What is that? Patient falls, right.
So students should be able to differentiate between Tullio and Tumarkin. Do not confuse between these two. This is the message from
Yes.
Madam.
In Tullio's, in Meniere's, in Tullio's, there is always a sound, history of sound exposure, but in Tumarkin's, there is not. And in Tumarkin's, there is a fall, sudden fall attack. Okay. So then mention 3 points of management for this patient. So like any other disease, there is 3 components. One is lifestyle modification. That means low sodium diet. Why low sodium diet? Right, right. Meniere's actually endolymphatic hydrops. So low sodium diet helps to reduce retention of the salt and water. Okay. And avoidance of caffeine, tobacco. And then comes to our pharmacological treatment. In acute case of Meniere's, we suggest vestibular suppression for very few days. Okay, chlorperazine, cinnarizine for 3 to 5 days. Because prolonged use, it causes delay in the central compensation. So if you use stemetil prolonged, then the chance of patient to get more vertigo attack, more chance of drowsiness and fall. Okay. And other than that, diuretics, just like you said, that sodium, low sodium diet, same principle. And antiemetic and beta histine. What is the mechanism of action of beta histine? Be specific, anyone? Everyone uses in the OPD. Martin. How this help in Meniere's? No. No. Everything can't be diuretics, no. So beta histine actually is ACE3 antagonist. So it releases histamine in the circulation. Because of histamine release, there is blood circulation in the inner ear, in the stria vascularis. So microcirculation is improved. That's why that vertigo is improving. Okay. That's include the pharmacotherapy. Then come to intratympanic gentamicin, though its used lastly. Refractory Meniere's, not not responding to any medications, then we can try gentamicin, intratympanic gentamicin, though various debate is going there. One thing, previously it thought that we use gentamicin weekly, 40 mg per ml, weekly injection can help. But nowadays, new guidelines came that no, you can use gentamicin, but dose is as it requires, not 40 mg per ml, but whenever the further attack is happening, then not routinely for 4 to 6 weeks, as needed dose. Okay. And the surgical option, that endolymphatic sac surgery and two destructive surgery, hearing destructive surgery, labyrinthectomy and vestibular nerve section. Okay. The last section is mention 2 points of difference in the history that could point to a diagnosis of BPPV. So, it's written there. Yes, the main differentiating is a time. Last hours in the question, BPPV always for seconds. And in BPPV there is always position change. Patient is telling that during I turn ahead in the bed, or during I looking up the roof or lying to the down, then the attack is happening. But in menias it's not. So, thank you.
Thank you, Dr. Tithi. If you have any confusion regarding this, you can discuss after the session or in between the sessions. Next, I shall go to the instrument section.
Just write down.
This will be dealt with Dr. Soumitra Kumar at the end of the session, please. At the end of the session. You write down your question. At the end of the session, will be permitted time. So, Dr. Soumitra, please.
So, this question is identify the instrument in the image. Can anyone volunteer? Anybody? What is the name of the instrument?
I am not showing the answer key for reason behind.
No, it's not a skeeter drill. How can you have two arms of a skeeter drill? Does a skeeter drill have two arms? Huh?
Varia perforator?
Yes.
Now
Okay, so it's a
as the
varia
answer is open, I
perforator.
am
It's a varia perforator. It is used for the varia technique of cochlear implant. It is also called Trifon perforator by the name of the surgeon who first made it. Trifon perforator. It's written. So it's a Trifon perforator with guard. So naturally, the next question comes to you that what are the different techniques for cochlear implantation? Can anybody volunteer? Yes. So transmastoid and transcanal. It is not actually transcanal. This is also transmastoid, but this is through a limited mastoidectomy. You are not doing a total mastoidectomy. You are just making a perforation, and you are reaching the mesotympanum. So that is the next question. That what is the procedure being done? It is thus the drilling of the tunnel for passing the active electrode. Otherwise, you do a mastoidectomy, you do a cortical mastoidectomy, and then you do a posterior tympanotomy, and then you expose the mesotympanum. But here, without doing a cortical mastoidectomy, so it's actually done to save time. But there are problems. Now, the desired dimension, the dimension is actually the distance between the guard and your burr. What is the size of the burr used here? It is 1.6 mm. 1.6 mm cutting burr, and the distance between the perforator and the guard should be less than 5 mm. So it is here, it is said the 0.5, 4 mm. So that there is a thin ledge of bone in between the canal and the active electrode, because otherwise there can be problems. If we know that if it goes under the skin of the canal, there is risk of rejection. So the intraoperative and postoperative complications, there can be facial nerve injury. So how do we guard the facial nerve? We are not seeing the facial nerve here. So how do we assure that the facial nerve is intact? What is the position? At which position of the canal do we drill? In this technique, varia technique. Yes, posterior superior is a big, yes, at the 11 o'clock. At 11 o'clock position, that is your best chance of avoiding the facial nerve. And you can have CSF gush or electrode insertion problems because it's a small canal and you don't know what is happening inside the canal. And postoperative complications are flap necrosis, rejection, TM perforation, electrode migration and wound infection. So these are the things we need to remember.
The session will be discussed by Dr. Tithi. This is on imaging the CT. On request, she does not want the answer key to be displayed to you at this particular moment, so I honor her request.
So, tell me, what anatomical landmark involved by the disease? What is this? Good, very good. Okay. What is the appearance called? Signet ring appearance.
Which
So-
one is the signet and what the ring represents? And signet? Vestibule. Very good.
Good, very good. So, what is the most probable diagnosis? And tell me one person, stand and tell.
Otitis media of squamous variety of which year? Otitis media of squamous variety, active squamous variety with complication, with labyrinthine fistula.
Be specific. You
With
are seeing the
labyrinthine fistula.
CT scan.
Complication is a broad term.
With
You have to
labyrinthine
specify the specific complication. Mention.
Yes, so it is right-sided chronic otitis media, squamosal variety
Okay,
with right-sided lateral semicircular canal fistula.
Okay, just I want to add something. Anybody wants to contradict this thing? Contradict the answer? She said it's cholesteatoma. Any other answer that is coming to your mind?
I think it can be facial nerve. It can be in facial nerve injury, facial nerve damage also, right? In this.
Sorry, it can be
No,
glomus
it's
tympanicum.
Yes, yes.
Glomus tympanicum.
No, there are no other features of globus retina. What I am trying to say is, just think. Yes, yes. Yes. Yes, yes. Iatrogenic. That is the answer I was thinking of. Why can't it be a complication of a mastoidectomy? You are seeing an empty mastoid. Okay. So it can be a post-mastoidectomy status where you have inadvertently injured. So that should also come to your mind. Even that answer is not wrong because you are not seeing the patient. It's just the CT
Because
scan.
the history is not provided.
History is
and
not
no
provided.
Other information is there.
Patient is not there.
Possibility of iatrogenic injury is also
So
there.
other than cholesteatoma, that should also, because we don't have other features of cholesteatoma here.
No history is given in favor of cholesteatoma.
So, next is two relevant investigations suggested for this patient. Anyone stand? It's easy question. It's already there. Other two.
Fistula test.
Yes. Many of them. And better to say pietonodiometry.
Electronystagmography you
Okay.
pointed. Should we perform electronystagmography with a perforation in the tympanic membrane? So it is better to opt for some other investigation related to COM. It could be pietonodiometry. Why not?
And
Why
better-
are you thinking of complication of cholesteatoma? It could be pietonodiometry, it could be fistula test, it could be digital X-ray chest even,
Yes.
because that is needed for the surgical correction of the patient. Only two investigations which are relevant. ENG in that extent is not that much advisable in this particular patient.
And also better to avoid caloric test. Better to avoid because there is.
You can go for air caloric,
Air
but
caloric,
not
yes.
frequently done at most of the centers.
Then the surgical option available for treatment. What will you do?
একটু মাইকটা দিন না প্লিজ, দুটো তিনটে একটু যদি ফ্লোরে রাখেন সুবিধা হয়।
Modified radical mastectomy and repair of the fistula.
It's better to say mastoid exploration.
Oh, yes.
Yes.
mastoid exploration.
Not
Exploration of mastoid
mastoid
and proceed
and
accordingly. Follow the
proceed
disease.
accordingly, follow
Do
the
not
disease.
comment and stamp that modified radical will suffice. It may end in canal wall down or at the most. Now the answer key for your easy reference, which will be again provided to your WhatsApp group at the end of the session.
Can anybody describe the fistula test, please?
We can do fistula test by changing the pressure of the middle ear and the external ear by pressing in the tragus, or if we have availability of the cegal speculum, we can use the cegal speculum to change the pressure in the middle ear, which will cause the patient to have either dizziness or we can see visible nystagmus in the patient.
Can you spell cegal speculum? Specific spelling of cegal speculum.
Sir, we
Yes,
can
sir.
also
Oh,
perform.
one minute. Cegal speculum spelling.
SHI.
No, no. Sir. Can anybody, without mistake, SIEGGLE SIEGLE apostrophe S is the cegal speculum spelling. SH nahi baba. Yo, please.
Sir, should we perform ear caloric test?
Yeah, I already mentioned. But that is usually
If
not
at all-
available in most of the.
If at all attempting a caloric
If
test
at
in
all.
this patient, we have to do a air caloric, we can't put water.
Thank you.
But what I was actually asking for is the complete description of a fistula test. Fistula test, just by increasing the pressure inside the canal, you get dizziness or nystagmus, that is not the complete thing. Yes, yes, tell me. So, the thing is that with each increase of pressure, there is bilateral conjugate deviation of both the eyeballs towards the other side. And with each release of pressure, the eyeballs return to the midline. But if the pressure is maintained for more than 20 seconds, there is a horizontal jerky nystagmus and the patient feels vertigo. This is the complete description.
Similarly, with this, you have to also know what are the situations where fistula is present in the LSC, but fistula test is negative.
So, false negative fistula test.
Situations where fistula is present, but fistula test is negative.
First condition.
Though this is not the purview of
Sir,
OSCE.
first
This is-
condition is there is presence of cholesteatoma, that is covering the defect, and second condition is dead labyrinth.
Third possibility
third
is faulty technique.
Uh,
Faulty technique is another possibility where fistula is present, but fistula test is not. Thank you everybody for this healthy discussion. Next station is on chart. This is on the shoulder of me to discuss. First question, what is the type of hearing loss shown in the audiogram? You madam, what is the type of audiogram? Hey, a type of deafness present there.
It is a right-sided conductive hearing loss.
Justify your answer. Why it is right-sided conductive deafness?
So as we can see, there is a if at 2000 bone.
No, only deep in 2000 Hz is not the criteria for
There is
right-sided
airborne gap.
conductive loss. This red colored marking are for right, are for red right side, and the markings definitely the symbols is for the right ear. Number 2, why it is conductive, not sensorineural, not mixed? Why? Side determination is through the symbols and the color.
So because the air conduction is not.
See, 3 components are there to discuss with the audiogram. One is air conduction curve, one is bone conduction curve, and another section is airborne gap. Here the bone conduction curve is normal in the early frequencies and in late frequency also. Bone conduction curve is normal. Air conduction curve has come down at the level of 40 at 250 Hz, and accordingly there is significant airborne gap also. So, fitting 3 components, it is conductive deafness. Now, the speciality, the second question, what is the classical finding in this right-sided audiogram? And the answer was in the second question also, it is for the right ear. So, if you pick this from there, there is no harm, it is mentioned in the answer also. This particular notch the dip
That's not.
at 2000 hertz, which is not sudden, which is a gradual dip, is called Carhart's notch. See the gradual dip at 500 hertz, there is some amount of dip, at 1000 more, and maximum is at 2000. This type of dip is called Carhart's notch. In contrary to noise trauma, where there is acute sharp dip at 4000 hertz, where both bone conduction and air conduction curve have the notch. Here only the bone conduction curve has a down. Next question is, why this occur? Any idea? Why Carhart's notch is there?
As the otosclerotic foci?
No, it is not specific for otosclerosis again. It may be suggestive of otosclerosis, but it can happen in other conductive type of deafness also. Do not get confused with this Carhart's notch that this diagnosis is for otosclerosis. Explanation?
See, the ossicles resonates at this frequency and also due to bone inertia.
In human ear, the ossicles are mostly resonant at 2000 hertz, and if this resonance is hampered by the fixicity of the ossicle, this type of notch is there, which may be seen in other type of conductive deafness also. With this audiogram in your hand during examination, do not stump to the diagnosis of otosclerosis, no. Now the last question, give two probable diagnosis from the audiogram. Anyone? You? Probable diagnosis from the audiogram. Yes? Yes, anything, any kind of conductive deafness. So any kind of conductive deafness, maybe otosclerosis, maybe any kind of fixation of the ossicular chain or OME even. So we should shift to the next station. This is on pharmacology. This will be again dealt by Dr. Tithi. She has opted for this with lot of expectations from you. So again the answer key is not shown at the beginning, because he will ask and you have to answer. Madam, please.
So, lignocaine, our bread and butter anesthetic.
Come on, kota number page.
So, going to first question, what is the dose per kilogram body weight for this medication? It is with adrenaline. So, what is the dose? Okay, right, very good. And if without adrenaline, what is the dose? 3 to 4.5. Okay. What is the maximum injectable dose of the above medicine that can be given safely to this patient? First tell, what is 2% LOX meaning? Anyone? Anyone stand? I can't hear everyone. Anyone stand and answer. What is 2% lignocaine mean? LOX mean?
20 milligrams in 1 ml.
How? How there is 20? Okay, look. 2%.
Very basic question for the drug which is used every day in the OPD, in the OT, in every situation. You have to know this. Very common drug, very popular drug, used by all. But many of us do not know the basics of this. And this is true. So let it be clarified from Madam.
Okay. So 2% log spray means it's in percentage. Okay. So 2 gram in 100 ml. Okay. So 2 gram mean 2000 mg. Just calculate then. 20 mg per ml. So 2% mean 2 gram. It's in gram, not in milligram. So what is the maximum? So now calculate. What is the maximum dose? 20 mg per ml. The patient's body weight is 70. You people told already that 7 mg per, that is the maximum. So 490. And as it is 20 mg per ml, so 490 divided by 20, it's 24.5.
Here is the calculation what Madam is trying to Insist.
7 maximum. Its range, upper range. We have taken the upper range.
Supposedly the patient's weight is 70 kg. You have to calculate accordingly. If it is 90 kg patient of yours or 110, then it will be definitely different. Maximum limit will increase.
So here one thing, if supposedly the patient is 90 kg, then the range is not in 7. There is a maximum range also. Okay. So maximum you can give 500 mg. You can't give beyond that. Okay. That is the toxicity level starting. 500 mg. As it is 490. As it is 490, it's... Yes, sir.
এই ক্যালকুলেশন ডোজের একটা জিনিস মনে রাখলে খুব সুবিধা হবে, সেটা হচ্ছে 1% 1 ml ইকাল টু 10 মিলিগ্রাম। যে কোনো ড্রাগে, যে কোনো কিছুতে 1% 1 ml 10 মিলিগ্রাম, তাহলে আর মানে বেশি ক্যালকুলেট করতে হবে না।
এত ভালো এক্সপ্লেনেশনটা উনি দিলেন, তার কারণ উনি আগে এস্টাবলিশ অ্যানেস্থেসিওলজিস্ট ছিলেন এবং এখনো আছেন। এই এক্সপ্লেনেশন আমার জানালে আমার কাছ থেকে শিখলাম।
Thank you, sir. And also you have to know the if there is no adrenaline, there is 3 to 4.5, and the maximum dose is 300 mg. You can't give above that. Okay. So the next question, please. Question, please. So the next question is, mention the effects of IV administration of the drug. So please tell anyone.
Tithi, if you permit.
Yes, sir.
May I request you to hand over the mic to Manoj?
Yes, sir. Sure, sir.
Once my student ফোনটা এই পুরোটাই লিগ্নোকেনটা তুমি
ও স্যার আমি ভুলে, আমার এতটা মানে এখনো মনে নেই অতটা। এনিওয়ে, সো ফার্স্ট তো ডোজ হয়ে গেল 7 মিলিগ্রাম ম্যাক্সিমাম injectable dose, and calculation is very easy for any type of drug. 1% 1 ml equal to 10 milligram. And inadvertent IV administration, yes, it happens. So generally the patient will complain of some sort of numbness, and there may be convulsion, and patient may become unconscious. And that is the inadvertent that thing that is, and there may be cardiac arrest also. And mechanism of action, probably some sort of that channel blocking, sodium, potassium, exact mechanism আমার মনে নেই। তিথি, তুমি mechanism of action টা বলে দাও, exact mechanism.
Sir, I want to share one of my experience during my PG days. There was a healthy young female patient, and she was planned for tympanoplasty, plain tympanoplasty, and in operative bed. The thing is, our juniors forgot to skin prick test. Okay, lignocaine sensitivity test হয়নি, then patient উঠেছে, and somehow the drug got intravascularly, and the patient went to ventricular arrhythmia. And then the patient is shifted to CCU, the operation postponed, but thankfully the patient saved. So be very, very cautious.
Yes, and you have to be very vigilant when you are giving that. If it goes in the IV also, you can save the patient by intubation, by providing oxygen or all this support system, because it is happening inside the OT. You can save the patient, but if it goes unnoticed, then it will cause the problem. And that arrhythmia partner, it is basically due to the preservative in this drug, not the drug itself, because often the physician and the cardiologist, they give the Xylocard in cases of tachy or in cases of arrhythmia for treatment.
Okay, thank you. Let us shift.
Last one. Last
please
question.
be first.
Yes. So what is the mechanism of the medication? It is a basically voltage gated sodium channel blocking. And the one thing I should emphasize, during lignocaine, what sensation first gone? Anyone know? What sensation first gone? It's pain, pressure, touch, what? It's pain. pain, dull pain first gone, because dull pain is C fiber, small unmyelinated fiber, small drug can, so first gone pain, and last is the motor. Last got the motor, but in the recovery, motor recover first, pain is last. Okay, yes. So,
Okay.
thank you, sir.
So for the next question, we require some volunteers. One female volunteer and two male volunteers. এসো বুঝিয়ে দিই, ওটা পড়ে নে। 50-year-old মেল এখানে আছে, তার স্পাউস তুই, ঠিক আছে? তোর হাজব্যান্ড, হি ইজ এ নোন স্মোকার, গিভস হিস্ট্রি অফ হোর্সনেস অফ ভয়েস ফর লাস্ট 3 months, ফাইবার অপটিক ল্যারিঙ্গোস্কোপি 1 মাস আগে করা হয়েছে, 1 month ago. It shows an ulcer proliferative growth involving the right ariepiglottic fold, false chord, true chord with fixity of right hemilarynx and compromised glottic chink.
Yeah, so the patient will be requiring a procedure called tracheostomy because this patient has come to us with distress. After this procedure, the patient will not be able to speak, and you will have to be you can't bathe in the swimming pool or etc. pond bathing. You can't submerge it underwater, and after this procedure, when the tracheostomy is done, the patient has stabilized. তো তারপর যখন পেশেন্টটা ঠিক হয়ে যাবে, পেশেন্টটা ভালো করে নিঃশ্বাস নিতে পারবে। আচ্ছা, পেশেন্ট মুখ থেকে নিঃশ্বাস নিতে পারবে না, পেশেন্টকে এই টিউব দিয়ে নিঃশ্বাস নিতে হবে। আর আমরা প্রত্যেক দিন ওটা মানে ওই যেটা ব্লক যদি হয়ে যায় আমাদেরকে সাকশন করে দিতে হবে, আমরা দেখিয়ে দেবো, আপনার বাড়িতে গিয়ে ওটা করতে পারবে। আর ওটা প্রত্যেক দিনে আপনাকে ওই আরেকটা নতুন নিয়ে নিতে হবে, ওটা পাল্টে নিতে হবে প্রত্যেক দিন বাড়িতে। আমরা দেখিয়ে দেবো কী করে করতে হয়। আর যখন পেশেন্ট ঠিক হয়ে যাবে, আমরা এই ফিটনেস করিয়ে পেশেন্টের সব ইনভেস্টিগেশনস করি। আমাদেরকে ওই পেশেন্টের এক ধরনের যেটা মনে হচ্ছে মানে একটা রোগ হয়েছে, যেটার জন্য আমাদেরকে একটা মাংস নিয়ে বায়োপসি করতে হবে, যার রেজাল্ট উপরে আমাদের মানে আগে যে ট্রিটমেন্ট হবে ওটা হবে। তো ওই ট্রিটমেন্টের মধ্যে ওই বায়োপসির রেজাল্ট হিসাবে আমরা ট্রিটমেন্টটা করব।
স্যার, এই অপারেশনের কী কী ক্ষতি হতে পারে, কী কী ডিসঅ্যাডভান্টেজ হতে পারে আমার কমপ্লিকেশন ওয়াইজ?
এই অপারেশন যখন আমরা করব তখন মানে এই আপনার শ্বাসনালীতে একটা ফুটো করে আমরা ওখানে ওই টিউবটা দেব। তো ওই অপারেশন মানে যখন আমরা ওটা করব তখন একটু রক্তপাত হতে পারে। আর যে ওটার পিছনে যে আমাদের খাদ্যনালী আছে ওটার মধ্যেও ফুটো হয়ে যেতে পারে। আর পেশেন্টের মানে এটা সাধারণত হয় না, কিন্তু এরকম যে শ্বাসকষ্ট হচ্ছে পেশেন্টের কিন্তু অপারেশন টেবিলে মৃত্যু হতে পারে।
স্যার আমার
এটা আপনার মানে অপারেশনটা লাগবে, নাহলে পেশেন্টের আস্তে আস্তে ওটা বেড়ে আর নিঃশ্বাস নিতে পারবে না।
আমার এক রিলেটিভের এই সেম জিনিসটাই হয়েছিল। এবার আমি শুনেছি নাকি এই অপারেশন হওয়ার পরে আর কথা বলতে পারবো না বা খাবারের স্বাদ পাবো না, এগুলো কি আমার ক্ষেত্রেও হতে পারে? তাহলে আমি কি করে, আমার তো একটা মেজর একটা লাইফ চেঞ্জিং মোমেন্ট হবে, আমি কি করে থাকবো?
তো হ্যাঁ, তো যতদিন এটা আপনার এই টিউবটা আছে, আমি যেটা বললাম, আপনি মানে কথা বলতে পারবেন না আর নিঃশ্বাসটা আপনাকে ওখান থেকে নিতে হবে। এবার যদি পুরোপুরি মানে এটার পর ট্রিটমেন্ট হয়ে যায় আর আপনার যে ডিজিজ যে সমস্যাটা আছে ওটা যদি সেরে যায়, তো আপনার এই তখন আমরা আস্তে আস্তে এটা সরানোর চেষ্টা করতে পারি। কিন্তু এটাও হতে পারে যে আপনার এটা যে অ্যাডভান্স স্টেজে যদি কিছু সমস্যা হয় এটা নাও সরতে পারে আর আপনাকে সারা জীবন এটা নিয়ে থাকতে হতে পারে।
আমার রোগ কি একদম সেই এন্ড টার্মিনালে চলেই গেছে যে আমাকে এই প্রসিজারই নিতে হবে? এর কোনো কি অল্টারনেটিভ মেডিকেশন বা কিছু কি নেই সার্জিক্যালি?
আপাতত আমরা বায়োপসি মানে ওই যে মাংস নিয়ে আমরা তো পরীক্ষা করিনি, তো আপনাকে এটা বলতে পারবো না যে কোন স্টেজে আছে, কিন্তু দেখে যেটা মনে হচ্ছে এটা একটু অ্যাডভান্স স্টেজে, একদম সামনে স্টেজে না।
আপনি এসব কি বলছেন? ও কি একদম কথা বলতে পারবে না?
হ্যাঁ, মানে
এখন যেরকম গলার আওয়াজ আছে এরকমই কি থেকে যাবে এরপরে? ঠিক হবে না?
কথাটা বলতে পারবে না, কিন্তু আমরা যখন ওই টিউবটা 2 দিন পর পাল্টাবো কাফ থেকে কাফ করে, তো আপনি এখানে চেপে আস্তে আস্তে কিছুটা কথা বলতে পারবে, কিন্তু মানে ওটা আগেই যেরকম বলতো ওই রকম অফকোর্স হবে না। কিন্তু যদি ডিজিজটা আমরা হোপ করি যে এই ট্রিটমেন্ট চিকিৎসার পর যে চিকিৎসা পর এটা যদি ঠিকঠাক হয়ে যায়, তো আমরা যদি টিউবটা রিমুভ করতে পারি অফকোর্স দেন তখন আগে যেরকম কথা বলতো এরকম বলতে পারবে, কিন্তু মানে এটা গ্যারান্টি অফকোর্স মানে আমি দিতে পারবো না, মানে আমরা আমাদের দিক থেকে পুরো চেষ্টা করব।
তাহলে আমি সার্জারির দিকে কেন এগোবো? মানে আপনি
এটা-
যখন আমাকে বলতে পারছেন না যে আমার পেশেন্ট ঠিক হবে কি না হবে।
আপনি সার্জারি কিন্তু না করলে এই যেটা এখন তো অল্প মানে যেখান থেকে নিঃশ্বাস যায় ওটা অল্পই বাকি আছে, এবার ওটা বেড়ে বেড়ে পুরোটাই ব্লক করে দেবে, তারপর পুরোই নিঃশ্বাস নিতে পারবে না, আর তখন পেশেন্টের মৃত্যু হয়ে যাবে।
না, পুরোটাই ঠিক আছে, বাট আই বেগ টু ডিফার। ডক্টর তিথি উইল কন্টিনিউ দ্য জার্নি। হ্যাঁ, ঠিক আছে। আরও কোথাও তিথি, ইউ শেয়ার ইউর পার্সোনাল এক্সপিরিয়েন্স ইন সাম পার্টিকুলার এক্সামিনেশন। ইউ ডু নট tell the name of the examination, but share your experience with the same case. I know she suffered a lot from that.
আচ্ছা স্যার, এই স্যার বলছিলাম পেশেন্ট তো এখানে বলছে অ্যাক্টিভ স্ট্রাইডারে রয়েছে, তাহলে কি কাউন্সিলিংটা
পেশেন্ট অ্যাকিউট স্ট্রাইডার হয়েছে বলছে না, পেশেন্ট তো এখানে
ওইখানে সিনারিওতে তো তাই লেখা রয়েছে।
আসছি তোমার সঙ্গে ডিসকাশন পরে হবে। তিথি এক্সপিরিয়েন্সটা শেয়ার করুক, শুনবো তোমার। আমাদের হাতে সময়টা কম, 4টের মধ্যে আমাকে শেষ করতে হবে, নাহলে পরেরগুলো ডিসকাস করতে হবে।
ফার্স্ট অফ অল কাউন্সিলিং স্টেশনের একটা বেসিক প্রোটোকল আছে, যেটা আমাদের দেশে এত পেশেন্টের মাঝে হয় না। তো ইন্টারন্যাশনাল যে কোনো
স্পাইকটা কিন্তু তোমাদেরকে ফলো করতে হবে। স্পাইকটাকেও অনার করেনি, ও ডিরেক্টলি এসে বলতে শুরু করেছিল কি করবে। এটা একটা পার্ট, আমাদেরকে স্পাইকের ডিটেইলিং এর সময় নেই। তুমি ওই জায়গাটা বলো যেখানটাই ওর বাড়ির লোক
যেখানে
কাঁদতে শুরু করলো, কিন্তু ও কিছু করলো না, মানে ও শুধু বলেই গেল এই করতে হবে ওই করতে হবে। সেটা তুমি বলো।
ডোন্ট হ্যাভ টু ফিনিশ দ্য পয়েন্টস। পয়েন্ট শেষ করার জন্য আমি এই পয়েন্টগুলো বলতে হবে এরকম নয় ব্যাপারটা। বাড়ির লোক যখন কাঁদতে শুরু করেছে বা প্রচন্ড অ্যাংশাস হয়েছে, ইউ শুড কমফোর্ট দ্য পেশেন্ট পার্টি। You should offer him a glass of water. You should talk to him.
মানে কিন্তু একবার ওকে অ্যাসিওর করলো না যে না কিছু হবে না বা আপনার কিছু লাগবে না, কিছুক্ষণ থমকে যেতে হবে ওখানে, ওটাই কন্টিনিউ করে গেল।
You should
দ্যাট ক্যানট বি। ঠিক আছে, আমাদের কিছুই না, কাউন্সেলিংটা আগে আমাদের জমানায় কখনো ছিলই না, আমরাও শিখছি নতুন করে। কাজেই এই স্পাইক প্রোটোকলটা আমরা ফলো করি এবং সেখান থেকে কিছু কিছু ইনফরমেশন নিয়ে আমরা স্পাইকসটাকে ফলো করতে হবে, এবং যেখানে ওরকম হাউ করে কাঁদতে শুরু করবে বা সেখানে নিজেকে থমকে ব্যাপারটা।
আমি একটু ব্রিফলি স্পাইকটা বলে দিচ্ছি, কারণ থিওরিটিক্যাল জিনিস ওখানে লেখা আছে, একদম শর্টে বলে দিচ্ছি।
আমাদের তিনজন ভলান্টিয়ারের জন্য একটা বড় হাত।
থ্যাংক ইউ, ভেরি গুড, ওয়েল ডান।
সো স্পাইকে প্রথমে বেসিক্যালি সেটিং, যেখানে কাউন্সিলিং করা হচ্ছে, খুব নয়েজি এনভায়রনমেন্টে কাউন্সিলিং নিশ্চয়ই অত ভালো করে করা যাবে না। তো একটা
স্পাইকের ডিটেইলিং এ যেও
না, ছোট
বাকিগুলো হবে না।
তো একটা সেটিং, দেন পি ফর পারসেপশন। পেশেন্টকে জিজ্ঞেস করতে হবে আপনি কতটা জানেন আপনার অবস্থা সম্পর্কে। দেন ইনভাইট করতে হবে, আই ফর ইনভিটেশন, জিজ্ঞেস করতে হবে যে আমি কি এখন আপনাকে তাহলে এক্সপ্লেন করবো, আর ইউ রেডি ফর দিস। দেন ডোন্ট গিভ দ্য সাডেন শকার, গিভ আ ওয়ার্নিং সাইন। তারপরে হচ্ছে নলেজ, তারপরে এক্সপ্লেন। মাঝে মাঝে ব্রিফ পজ দরকার, কারণ পেশেন্ট পার্টি তাদের কোনো কোয়ারি থাকতে পারে, জিজ্ঞেস করা দরকার যে তাদের কোনো কোয়ারি আছে কি না। দেন ইজ দ্য এমপ্যাথি, এই যে লাস্ট যেটা হলো, যে যখন খুব অ্যাংশাস হয়ে গেছে, হি শুড কমফোর্ট দ্য পেশেন্ট পার্টি। ওকে,
থ্যাংক ইউ ফর দ্য ইন্টারেক্টিভ সেশন, থ্যাংক ইউ ফর দ্য ভলান্টিয়ার্স। Here is the next station on dope. Can Siddhanto tell what is the full form of DOAP, dope? What is dope? এটা কি ডোপ টেস্ট? ডোপ টেস্ট তো নয়, তাহলে ডোপটা কি? ডোঅ্যাপটা কি? বেসিক্যালি ডোঅ্যাপ
ডেমনস্ট্রেশন,
লেখাই আছে নিচে, ডেমনস্ট্রেশন, অবজারভেশন, অ্যাসিস্ট্যান্স এন্ড পারফরম্যান্স। হ্যাঁ, এটা ডেমনস্ট্রেট করে দেখানোর কথা, সেই জিনিসগুলোই এখানে দেওয়া ছিল। এর আনসার কিগুলো আলাদা করে ডিসকাস করার কোনো জায়গা নেই, তোমরা ছবিগুলো দেখে আনসার কিগুলো চেক করে নাও, ওখান থেকেই পেয়ে যাবে কি করতে হবে। একটাই জায়গা ডিসকাস করার ছিল, কিন্তু ক্রাঞ্চ অফ টাইমে ওটা করা যাবে না। হাউ টু প্রিপেয়ার অরাল শো অফ দেয়ার। This section, audiology, osteology, is discussed in detail by Professor Subrata Mukherjee. So, we are not going into detail of this, just check the answers. Check with your answer script, rectify theirs. If it is done, we shall shift to the next session. The slides will be dealt by Dr. Tithi.
So what is the diagnosis? Rhinosporosis, very good. So in the histopathology, level A, B and C, okay, there is three things to remember. A is the, what is the pathophysiology for rhinosporosis? There are, yes.
Implantation of spores.
Good. There is endospores is there from the sporangium and from the traumatic nasal mucosa, they invade there and causes the granulation tissue and fibril masses. So, sir. So, A is the mature sporangia. Okay. Why is mature? It has the thick chitinous outer layer, spherical. So, this is the spherical chitinous structure and densely packed endospore. So, it is the mature one. And this is immature one, this is less densely packed and this has ruptured endospore. Okay? And how can the recurrence be prevented? There is cauterization of bases to arrest the growth of endospore and use of dapsone. Okay. Just remember one thing, before giving dapsone, ask the patient if the patient has G6PD deficiency or not, because it is contraindicated. It causes severe hemolysis. Okay.
Last session, specimen will be discussed by Dr. Soumitra. Please.
So, anybody wants to tell me what is the name of the full name of the surgery? What surgery had been performed on this patient?
I am not showing the answer key at the beginning. At the end, I shall display.
Anybody?
Well done. Well done.
Total laryngectomy with bilateral selective neck dissection.
Anything else? Total laryngectomy and?
Total laryngectomy with hypophysectomy.
Sir, total laryngectomy, laryngopharyngectomy, left hemithyroidectomy with reconstruction of neopharynx.
এটা কোশ্চেনটা আউট হয়ে গেছে তাই ও বলে দিল, ওটা অন্য কিছু দেখে ও বলল।
No, okay. Reconstruction of neopharynx you can say, because without reconstructing the neopharynx you don't close the patient.
ওটা আগের বারে
So obviously you have
ইউটিউব লিংকটা দেখেও
you have done.
ইউটিউব লিংক দেখে বলেছে, কোশ্চেনটা চেঞ্জ করতে হবে আমাকে নেক্সট টাইম। So let us display the answer key also. কোশ্চেনটা চেঞ্জ করো, কোশ্চেনটা চেঞ্জ করো আজকের মধ্যে 10টা।
Yes, so what is the minimum T stage for a transglottic cancer? Yeah. Okay, so that is something we don't need to discuss. Now identify the structure marked by the red arrow. Can we see the structure? So it's a which side? Right side. So right side thyroid lobe. So that has also been sacrificed. So why did we remove the thyroid? Okay, probably due to, yes? No, it is due to the transcartilaginous spread of the tumor. And what are the preoperative preparation? That in what preoperative preparation, what we have to see? Yes. Yes. So that is something most of you know, that what is the normal pre-op workup plus these things which are specific to laryngectomy, and 3 methods of restoring speech after this.
Esophageal voice, pneumatic larynx, which is TEP prosthesis, and electrolarynx.
যে কোনো টেক্সট বুকে এটা বলে হোয়াইট ফিল্ড টোটাল ল্যারিঞ্জেক্টমি, হ্যাঁ পার্ট বাই পার্ট না বলে এটা বললো দ্যাট ইজ অলসো অ্যাকসেপ্টেবল। হোয়াইট ফিল্ড টোটাল ল্যারিঞ্জেক্টমি।
স্পেসিমেন যেটা ফ্যারিঞ্জেক্টমি হয়েছে কিনা ওটা কি করে বুঝবো, মানে স্পেসিমেন থেকে, মানে ফ্যারিঞ্জেক্টমি হয়েছে কিনা?
বেসিক্যালি হচ্ছে ল্যারিঙ্গোফ্যারিংস, যেটা থেকে ফ্যারিঞ্জেক্টমি ইজ আ ইনএভিটেবল পার্ট অফ ল্যারিঞ্জেক্টমি। You cannot remove the larynx without partial excision of pharynx. You have to remove that pyriform fossa, that posterior wall, you have to remove part of the pharynx. You have removed the larynx, so pharynx is open. Now reconstruction, that is the neopharynx. And the term is the white field total laryngectomy. In part you can describe.
Okay, thank you.
Anybody who has seen the relation of the hypopharynx with the larynx? The larynx actually sits inside the hypopharynx, and there are two pyriform fossas which are coming inside it. So if you want to cut the larynx, you have to cut those things. You have to cut the pyriform fossas. So that is why hypopharyngectomy, partial hypopharyngectomy, is always a part of total laryngectomy. There is nothing called a total laryngectomy without a hypopharyngectomy. So that is why what he also said, that with reconstruction of the neopharynx, because without reconstruction of that pharyngeal part, you are leaving a fistula. So that can't be.
So now, if any doubt is there among yourself, you can ask 2-3 questions, please. Two or three questions.
We have some time for 2 or 3 questions.
So what are the exact criteria when we'll say that the tumor is transglottic, sir?
Transglottic when it vertically involves, not the horizontal, vertically involves the superior or inferior part. Say it is glottic, it is going superior, it's transglottic. Not the horizontal progression, but vertically. Say it is glottic, it is going subglottic, it's transglottic.
Sir, if the glottis has only gone to supraglottis and not gone to subglottis, can we say it's transglottic, sir?
Pardon?
Sir, if it's a glottic CA and it has only gone to the supraglottis region, not involving the subglottic region, we'll say it's transglottic.
No, it is transglottic means it must involve the glottic. Say subglottic, it is going to the superior part, it is transglottic. It should involve that glottic part, and the vertical extension is superior or inferior.
Radiological evidence of invasion of the paraglottic space. That is the best, because if it involves the paraglottic space, it has to be transglottic, because there is no other barrier in the paraglottic space. So if it is in the paraglottic space, you can safely say that it's transglottic.
Thank you, sir.
Transglottic bola jabe kono provisional diagnosis of a long case, can I say it is a transglottic growth?
Yeah, supraglottic growth or glottic growth eksange hole transglottic bolbe na bolar ki? Provisional diagnosis, that is not confirmed.
If you get enough evidence from your clinical examination, because in the examination you only get a clinical examination, an indirect laryngoscopy, not more than that.
The diagnosis is provisional, not confirmed.
So provisional diagnosis,
you can mention this
you
is
can say it's a transglottic growth, because you are not seeing radiology there, you are not getting a 70-degree scope there. Yes, multiple subsets.
You provisionally diagnosed as transglottic may at later part turn into non-transglottic, no harm.
The thing is, whatever you say, you have to stand your diagnosis.
Okay, thank you everybody, and we are in time to finish. Thank you.
Okay, so
just wait for a last group photo. Before that, we hand over the certificate to our faculties, Dr. Sumanto Dotto, Dr. Soumitra Kumar, Dr. Tithi Devnath, and সবাই বাড়িতে গিয়ে ভালো করে মাথা ঠান্ডা করে চান টান করে ফ্রেশ হয়ে তারপরে একবার বসে ভাববে কি কি হলো দুদিনে, তারপরে যা যা মনে কোয়েশ্চেন্স ডাউটস আসবে সেগুলো তোমরা গ্রুপেতে দিতে পারো। গ্রুপেতে যারা ফ্যাকাল্টি থাকবেন তারা অ্যান্সার দিয়ে দেবেন বা বলে দেবেন, ঠিক আছে?
So please come forward for one group photo. That is, we'll conclude the 2 days PG orientation program. Hope you will do for all the best for the upcoming PG exam, and hope you will associate with our association for long life, and that will be very helpful.
চলে আয় সবাই, প্লিজ কাম।
Please come forward.